Hello, everyone, and welcome to the 2023 Jessamine County EMS RSI DSI in-service training. First, I want to start off by saying that this training will be a little long. I'm going to try to separate it into parts so that it's not exorbitantly lengthy for you. But it might take up a lot of your bandwidth. So if that is the case, then I ask that you take a break if you need to step away and come back to it so that it is more palatable. The quizzes at the end will be difficult, and you will have limited attempts at taking those quizzes. So make sure that you pay attention during the video. All right, and let's go ahead and get started. And first thing I wanted to talk about was the evidence. A lot of people want to know, what is the evidence for RSI, especially pre-hospital RSI, because in the hospital it's kind of well established, but there was a time when people did not want physicians to, or emergency physicians, I should say, to perform RSI. So what I like to ask people is, what is the evidence for using a parachute when you jump out of the plane? And why do we use a parachute? Why not just jump out of a plane and see what happens? Well, of course, they're never going to perform a randomized control trial comparing jumping out of a plane with a parachute compared to jumping out of a plane without a parachute, because that really just doesn't make a whole lot of sense now, does it? So there is some evidence, and I will argue that the evidence isn't necessarily that great. If you look at, the areas that are probably the most studied in terms of pre-hospital intubation overall and pre-hospital RSI are traumatic brain injury and cardiac arrest. And I could have easily pulled some studies showing improved outcomes in both, but I chose to show a study that had mixed results, especially with traumatic brain injury. I would say that the literature in pre-hospital TBI shows that if you perform RSI well, when you're performing RSI, when you're intubating a patient with TBI, then the outcomes are better. Conversely, if you don't do it well, then the outcomes obviously are worse. And in a lot of services where they compared RSI to no RSI, they've compared it to services that previously weren't doing RSI, or they had horrible intubation success rates overall. So you have to take those with a grain of salt. But some do show improved survival if it's expertly performed and if the patient has a more severe TBI. So it's really, really indicated. So there's evidence for that. In cardiac arrest, mostly evidence of harm. In the majority of cardiac arrest studies that you find, there's mostly evidence of harm. But there's some data showing that the outcomes are improved. And here's what I tell people when they ask me about using or intubating patients in cardiac arrest versus drop-in a supraglottic device. How is it different? How is securing the airway with the supraglottic compared to endotracheal intubation different? And my argument there is that it's not, except in this scenario with the supraglottic or with BVM ventilation. You have the option, you can still hyperventilate, but even if I hyperventilate with a BVM or a supraglottic, there's usually a leak. Whereas if I've got a BVM with a PEEP valve, there might not be a leak, and it's not necessarily easier to hyperventilate, but the consequences of that hyperventilation are greater because that pressure stays within the chest. So I like this rock primed study, the Resuscitation Outcomes Consortium, because the EMS services that are enrolled in most ROC studies are high-performing EMS services. So I like to think that if they do well, we also do well. So if you look at the data from a high-performing EMS service and it shows that intubation improves outcomes, then I would like to think that it would improve outcomes at Jessamine County EMS as well. So let's look at another study. And this study was on the incidence of transient hypoxia and pulse rate reactivity during paramedic rapid sequence intubation. And the thing that's interesting in this study is it was a small study. They only had 54% of patients, but of those, they only had 54 patients, 31 of those, which constituted 57% of the patients, had desaturation. That's SpO2 desaturation during RSI. 84%, so 26 of those who desaturated occurred in patients whose initial SpO2 was greater than or equal to 90%. First of all, that tells us that maybe 90% is not a high enough target. All right. 6 patients had marked bradycardia, which they define as a pulse rate less than 50 beats per minute during the desaturation event. What I find most interesting in this study is that the paramedics, the majority of time, they thought that the intubation was easy. They described it as easy, although the patients did desaturate. So it may have been easy, but it was not helpful for that patient for sure. So this is another interesting study looking at the evidence, and you'll see that in this study, the trial included 87 patients. They attempted the intubation in 83% of the patients when the SpO2 was above 90%, and 83% of the patients, only 6% of those, the 83% with an SpO2 above 92%, experienced desaturation to 90%. What I found most interesting out of this study is that 59% of all patients who required more than one attempt, okay, so multiple intubation attempts, had an SpO2 value higher than their initial SpO2 value, okay? So we have to ask ourselves, why was it that the initial SpO2 was lower than when they decided to abort the intubation attempt because they missed it? They did something different, and then on the subsequent intubations attempts, the SpO2 was higher. How could that be? So the reason is that they then ventilated with a BVM. The patient's still apneic, they're still paralyzed. They ventilated with a BVM before they attempted again. And this runs contrary to everything that we are taught with RSI. So with rapid sequence intubation, it goes against the fundamental tenets of performing RSI, which is you don't ventilate the patient. That's why it's rapid, is so that you can immediately provide a sedative, a paralytic, and then intubate the patient. So that's just something to think about. And now we're going to go over part 1, which is the background. So what is RSI? I've already kind of covered that. It is the nearly simultaneous administration of a neuromuscular blocking agents and sedative hypnotic drugs. So generally the sedative hypnotic. We call that the induction agent. Generally, that's given before the paralytic because we don't want to risk for, we don't want there to be any risk of that patient being paralyzed and not sedated. But because of the time of onset and the mechanism of action of those medications, we can give that sedative and then immediately follow with a paralytic agent so that they're both going to be working nearly simultaneously. So, and of course, the purpose is to facilitate intubation of a patient with the least likelihood of trauma, aspiration, hypoxia, and other physiologic complications. Now, RSI does provide muscle paralysis. It reduces masseter tone. So if the patient's clenched or has any trismus, it really loosens that up. And studies have demonstrated time and time again that intubation is more likely to be successful if you use a paralytic than if you use a sedative alone, because you can sedate someone to the point where they're unconscious with a GCS of 3, and it still be difficult because they still have some degree of masseter tone. And the whole point, again, to reiterate, in RSI, in the traditional sense, with the traditional definition of RSI, is to not have to ventilate that patient due to a fear, maybe not really an appropriate fear of gastric insufflation with bag valve mask ventilation. Because, and I have to go back because this paper is arguing that it might be justified and it might be more appropriate to aggressively ventilate this patient. It might be more appropriate to aggressively oxygenate and ventilate this patient with a BVM to prevent hypoxia, because the risk of hypoxia, or the benefits of normoxia, bringing that SpO2 up with a BVM, the benefits of that are greater than the risk or perceived risk of gastric insufflation and regurgitation and aspiration. All right, back to the background. So, you may have noticed in our protocols that there are two different types, if you will, of using a paralytic, okay? There are going to be two different protocols, two different procedures, and you have to determine which patient needs RSI and which patient needs DSI. So when I'm thinking, do I need to use RSI for this patient? Or when do I need to use DSI for this patient? Well, it depends. So RSI we should use on a patient who will permit us to escalate our oxygen therapy. So this is a patient that is tolerating our pre-oxygenation and oxygenation efforts, all right, who's allowing us to either put a non-rebreather at 15 and a nasal cannula at 15, or a patient maybe with COPD who's allowing us to use BiPAP and who's tolerating that BiPAP. We've got the SpO2 up to like 99%. We're able to maintain that for 3 minutes before we push the sedative and the paralytic. We're able to do that, all right? So another example is an obtunded overdose patient that's not reversible, so it's not, they're not responsive to Narcan, but it's some other type of overdose. Maybe they've aspirated a little bit and you think they need airway protection, but they're allowing you to pre-oxygenate. So we're already ventilating them with a BVM. Then that patient would be a good candidate for rapid sequence intubation. Now, what about delayed sequence intubation? So think of delayed sequence intubation as using ketamine for procedural sedation. And the procedure that we're sedating them for is pre-oxygenation. This could be an agitative, hypoxic patient, or maybe hypotensive, and you're trying to treat them and they're just not letting you. So we want to administer a dissociative dose of ketamine, IV, or maybe even IM, in order to effectively resuscitate them before we try to intubate. And this is kind of how I look at it. There's a small space between the administration of the induction and the paralytic. So for RSI, we would be able to oxygenate them, ventilate them, and then we go sedative paralytic intubation. For delayed sequence intubation, we cannot initially pre-oxygenate them, so we go sedative, ventilation, oxygenation, resuscitation, then paralytic, and then proceed with intubation. So that's how that works. Okay, so here are the complications. Not entirely impossible to avoid if done well, and these complications were probably pretty normal circa 2010, earlier than that, before, when people thought that RSI meant that you had a patient that needed intubation and you didn't need to optimize anything prior to intubating them. Now we know the harm that's associated with not optimizing the hemodynamics and the physiology before intubation. And take a look here, greater at the very bottom, right here, greater than 3 attempts. There was one study showing that the risk was around 10%. So these are avoidable. And if you're in a situation where you think that these are not avoidable, then we frankly would not want to perform RSI on these patients. So if you do a proper risk assessment and you think this patient is likely to experience cardiac arrest if I take away their compensatory ability and they're not able to breathe during the apneic period, or maybe I can only get the SpO2 up to 60% with BVM ventilation, then, it would not make sense to induce apnea and paralysis in that patient. Okay, in part 2, we're going to cover the pharmacology. So we're going to go through some RSI medications. In the general sequence, just the medication sequence, not the full RSI sequence. This is just the pharm sequence. It's induction, paralytic, and then you provide post-intubation management with analgesia and sedation medications. Now, this will always be the sequence regardless of if you're doing RSI or DSI. The difference is that there might be a space here between the induction and the paralytic sequence. So the ideal induction agent would be one that does not cause hypotension, that does not cause respiratory depression, that allows the patient to breathe on their own, has no cardiotoxic effects, that improves cardiac output when you give it. Now, you might be thinking that that's ketamine. That's just not true. Ketamine can and will and does cause hypotension. It does cause respiratory depression. And sometimes it's dose dependent, but sometimes it is not, because ketamine requires endogenous catecholamines to maintain that tachycardia, that cardiac output. And if the patient has already exhausted their endogenous catecholamines, then ketamine can make that worse. Now, while it's not the perfect induction or sedative hypnotic medication, it's one of the best that we have. So the goal of administering ketamine or any induction agent, it'd be the true if we used etomidate or Versed, which, Versed isn't great because it can cause hypotension more so than almost anything else would be given, is to ensure that patient becomes unconscious and that they won't remember the procedure. So if that was not a concern, then we would just push a paralytic. But it is not really ethical to paralyze someone and them still be aware of what is going on. The dose is, or the onset of ketamine is around 45 to 60 seconds. The duration, it lasts a good amount of time. So if you imagine you're given ketamine and then you want to pre-oxygenate a patient for around 3 minutes, and then you paralyze them, and then, let's say that whole sequence takes 4 or 5 minutes. You intubate them, you put them on a ventilator. You don't have to immediately rush to provide any post-intubation sedation. It should be first on your list to do once they're on the ventilator, but it's not anything that you have to think, okay, they're intubated now, we have to immediately administer ketamine. So the good thing about ketamine is that the patient can maintain their airway reflexes and breathing after ketamine, but that's not always the case. So it's a can. They can do that. It's not a guaranteed. However, conversely, ketamine can also cause laryngeal spasms, for which we perform Larson's maneuver. It can also make the patient have hypersalivation, which, isn't a major concern, especially if we lead with suction. They can have a rise in blood pressure, which is almost clinically relevant for the patients that we're going to be treating. Historically, it's taught that ketamine is contraindicated in patients with TBI for that reason. But that is no longer the consensus, because they've done studies where they've had patients undergoing surgery and they were measuring the intracranial pressure in the brain. They had a catheter in the brain or in the head, and they administered ketamine, and they did not see a rise in intracranial pressure. And I heard this from a surgeon as well. So he was fast to dispel any myths at some training we were having on giving ketamine to patients with traumatic brain injury. Now, of course, it is ideal for patients who have shock, who have hypotension. Also for patients with asthma, bronchospasm, reactive airway disease, because it is a bronchodilator. It's not the best. That's why we don't just nebulize ketamine to everyone, but it does have those properties. So what is the dose? Well, generally, it's 2 mg per kg, IVIO, for induction. Administer it slowly. If you push it rapidly, it can cause apnea. Remember, we want them still breathing, especially if we're performing delayed sequence intubation. And honestly, we want them breathing up until they become apneic, because that's when we want them to be able to maintain their SpO2 saturation up until that apneic point, which is the point in which we're going to remove the BVM from their face. Now, if their blood pressure is low or they're elderly, they might be particularly sensitive to ketamine. So we have the dose. We give 1 mg per kg to those patients. That's a very important point to remember. The opposite's true of paralytics. With paralytics, it's better to err on the side of caution as opposed to induction agents or sedatives. If they are hypovolemic, hypotensive, we do have the dose. Now, ketamine is dosed based on the ideal body weight, not actual body weight. All resuscitation medications it's recommended that you dose based on actual body weight, not ideal. Ketamine is different. There are formulas. We will have a cheat sheet on your checklist, on your RSI, DSI checklist. But this isn't hard to commit to memory. So the way you calculate ideal body weight is you estimate their height, and generally estimating their height is better than estimating their ideal body weight just empirically, and that's just my anecdotal experience. We're not good at estimating the body weight, but we're generally okay. We can look and see how see how tall someone is and compare that to our own height, and then subtract or add from there. So the rule of thumb is that for males, and our example here is a 5'10" person, and if it's 5'10" male, you start at 50 kgs. So if they're 5 feet even, then their ideal body weight would be 50 kgs. Okay, so for every inch over 5 feet, you add 2.3 kgs. So if this person is 10 inches over 5 feet, then 10 times 2.3 is 23. And then you add that to the base of 50 kgs at 5 feet, and then you get 73 kgs. For females, the math is the same, except with starting at 50 kgs. For 5 feet, you start at 45 kgs. You start at 45 kgs. Now remember, we calculate tidal volume based on ideal body weight as well. And what machine do we have that will calculate ideal body weight for us? Our ventilator. Yes, good job. So paralytics, what do they do? How do they work? So here's the too long didn't read version of this. And if you want to look more, if you want to research more into this, then you can. Here's to the acetylcholine at the postsynaptic receptors, and it hyperpolarize. Succinylcholine is a depolarizing agent, so it is continuously disrupting at that motor end plate, and that's why you get the fasciculations with acetylcholine. The other paralytics, such as rocuronium, vecuronium, they actually block the receptors at the motor end plate, so they are competitive, which is how we think of most medications that we give to reverse. Most reversal agents that we give, most of them are competitive. Now, the main difference is that competitive paralytics, vecuronium, rocuronium, they last longer. They can last 30, 45, maybe even more minutes compared to succinylcholine. So here's a breakdown of kind of what this looks like. And this is the picture version of how succinylcholine, which is a depolarizing agent, works compared to those that are non-depolarizing. So succinylcholine has a very fast onset. For years, succinylcholine has been the go-to paralytic. Only recently has rocuronium and vecuronium, mostly rocuronium, gained popularity. And we could probably talk all day about the pros of succinylcholine versus the pros of rocuronium. And in the majority of head-to-head studies that you're going to look at comparing succinylcholine to rocuronium, it's pretty much a tie. There's no clear-cut winner on what's better. They both work just fine, but you have to understand each. The thing to understand about succinylcholine is the fasciculations, the list of contraindications, because there are many. The benefit of succinylcholine is that it has a short half-life, so the duration 6 to 10 minutes. So that is shorter than ketamine, okay? So that's a good thing. So that is a positive thing about succinylcholine. We don't necessarily have to worry about the paralytic, the duration of action of the paralytic being longer than the duration of action of our induction agent, because then we risk a patient being paralyzed and not sedated. That's also a negative thing about succinylcholine in a manner speaking, because if we require multiple intubation attempts if we require multiple attempts at intubation to secure that airway, then eventually 6 to 10 minutes after the onset, that patient is going to lose that muscle paralysis, and succinylcholine could theoretically possibly have to be redosed. But it shouldn't in 99.99 something percent of cases. Now, the dosing is 1.5 milligrams per kilogram of actual body weight, not ideal body weight. And again, it is better to give a larger dose and err on the side of caution with a paralytic. It is much better for the patient to be fully paralyzed than not paralyzed enough. The thing is, though, the larger the dose, the longer the duration of action. Okay, the larger the dose, the longer the duration of action. Again, that's not necessarily a bad thing, especially if you have a difficult airway, you can't secure the tube, you paralyze them, you try to ventilate with a BVM, that's not successful. You try iGel, that's not successful. The rapidly desaturation, what do? Well, following the airway vortex paradigm, we would proceed with what? A surgical cricothyrotomy, and we would not want to do that with the patient waking up. Fortunately, the duration of action of ketamine is longer than the duration of action of succinylcholine. So there are some precautions and some contraindications to succinylcholine. Now, most of the contraindications we can rule out because we're usually not going to see those patients in that time frame. So if you look over here at burns greater than 5 days, okay, we shouldn't see anyone with massive burns that have had those more than 5 days that have not been to the hospital. Crush injury, if it's a large body, large muscle mass, so if it's like the thigh or if it's multiple body parts that have been crushed, because again, succinylcholine does cause a small, usually clinically irrelevant increase in the potassium up to 0.5 MEQs per liter, which is a small increase. If they have a severe infection, I don't know what constitutes a severe infection, but if it's an extremely severe infection, a relatively absolute contraindication to the administration of succinylcholine is a history of malignant hyperthermia. That is a absolute contraindication, and neuromuscular disease. So if they have Guillain-Barré syndrome, ALS, multiple sclerosis, you want to be very careful to not administer succinylcholine. Now, in many of those situations, we might not know. So if you know, then obviously don't do it. But if you don't know and there's an adverse event, it frequently is manageable. You can get laryngospasms occasionally, either after the administration of succinylcholine. The SUX abbreviation is not appropriate. It should be SCH, but SCH is a good abbreviation for succinylcholine. But this can also occur after the administration of ketamine.
Laryngospasm, a common complication after extubation, can be treated by the Larsen maneuver. To perform the maneuver, first locate the laryngospasm notch behind the lobule of the pinna of each ear, anterior to the mastoid process of the temporal bone, and posterior to the ascending ramus of the mandible. Press the middle finger firmly on the notch in a cephalid direction. Some degree of jaw thrust may also be applied.
So you can perform Larsen's maneuver as you're using your two-hand seal, as you've got the mask on the face, and you are pulling that chin into the mask. If you do a jaw thrust and you push at that notch, then you can help relieve laryngeal spasm. So other paralytics that could be used in the future that you might see used in the hospital is rocuronium. This is, the onset is generally a minute, and in cases where rocuronium is used for RSI, now this is postulated, if the intubation success rate is higher with succinylcholine, a lot of people theorize that it's because you don't wait long enough before you attempt intubation. You don't wait until there's full muscle paralysis. Now, the key, the hallmark thing about rocuronium is that the duration is long. It can last anywhere from 30 to 60 minutes, which some say is a good thing because if the patient's undergoing RSI in the ER or in EMS in the pre-hospital field, you have no choice but to proceed with securing that airway. You're not performing the procedure of intubation because the patient's undergoing a routine appendectomy or something. You're doing it because you have to get that airway secured. Now, I did not mention, but now is a good time, succinylcholine does require refrigeration, but it is good for up to 2 weeks after it's removed. It's got a pretty wide temperature range for it to be refrigerated at, so it is not it's not a major concern, but it should be refrigerated, and it will not lose its potency for up to 2 weeks after you remove it from the refrigerator. This is the preferred paralytic when succinylcholine is contraindicated, but after many discussions on this with our medical director, and based on his experience using succinylcholine in the ED, practically speaking, the contraindications to succinylcholine that you're going to see are pretty rare. And there are no known contraindications to rocuronium except for a patient that does not need rocuronium. We do not give succinylcholine for continued paralysis. It is not ideal to have to repeat succinylcholine. You can if you must, but it's not ideal. And once you secure that airway, continued paralysis is very rarely indicated, so we did not include that in our protocol. Ketamine is used as our post-intubation sedative and analgesic. Now, you can use other things as an analgesic. You can use fentanyl, but it is important to note that you will not want to administer Versed in isolation for post-intubation management because it does not have any analgesic properties. It only has sedative, anxiolysis properties. Now, if you choose to give ketamine, which is what we're probably going to do most of the time, it provides analgesic and sedative properties. There may be times where, we're going to use ketamine for induction, but you're thinking this patient has a TBI, their blood pressure is through the roof. I might want to bring that down a little bit, so I'm going to give fentanyl and midazolam or Versed. Fentanyl has a fast onset of action. I think fentanyl's a great drug. And, if you're giving ketamine and maybe the blood pressure's low, but you want to kind of blunt that sympathetic response, you can give fentanyl in addition to administering the ketamine. You don't have to just give ketamine alone, but we generally wouldn't administer ketamine, fentanyl, and Versed unless you're giving Versed because the patient is having an adverse reaction to the ketamine. So they're in the no man's land between the analgesic dosing and the dissociative dosing. For sedation, again, ketamine can work both ways, or you can give Versed for post-intubation, but not alone and not for induction. It has a pretty long duration of action. Versed's a great drug. It's a great choice for post-intubation sedation when needed.